Alrighty, so why don't we go ahead and get started here, and maybe some of our colleagues can join us late. So I give this talk every year, like usually for introductory, as an introductory talk, usually to the medicine residents, but it's about rapid diagnosis in ID. And maybe what we can do today is have a dialogue about ways we can rapidly diagnose things. As a matter of fact, I think we can all think of ways that we're rapidly diagnosing infectious diseases nowadays that perhaps we did not 10 or 20 years ago. So it's kind of exciting that things are kind of progressing in that way. And so why is rapid diagnosis in ID important? Well, early diagnosis improves efficiency. And as we become more busy in our practices here, and as those of you who move out into the outside world of private practice ID, where you need to be efficient in seeing patients, you have to see 20, 30, or 30 patients a day, becomes even more important. Early diagnosis is not just better for us, but it's better for the patient, right? Because the earlier you diagnose something, the more likely you are to treat it more promptly, and the patient is likely to do better. Lab studies are increasingly standardized. I think that's true in the institution that we're all practicing in now, and also the institution I'm standing in. Hey, Joe. So if a test is not immediately available, if it can't be done in-house, it gets sent out. For some of our institutions, it may get canceled by pathologic review. For others, it may take so long that we don't get it back in time for it to be relevant. So if we can make a rapid diagnosis, that's very important. Rapid diagnosis, and I think this is true to all of us here, is more cost-effective too, right? I mean, if we can make a rapid diagnosis and we don't need to send out a test, chances are it's going to be more cost-effective for the hospital and for our practices. So I've put together a series of case studies to kind of help us think about this concept and apply it to hopefully real-world patients. And these cases are not meant to be hard, they're meant to provoke thought. So if you come up with this diagnosis right away, it's expected. But so a young patient who presents with a 2-day history of fever to 103, chills, right pleuritic chest pain, dyspnea of exertion, cough productive of greenish sputum, and has a high fever, 102, tachypnea, tachycardia, and has some findings on physical examination that are I think, pertinent positives, marked leukocytosis and bandemia. So what are we dealing with here? Sounds like a community-acquired pneumonia, right? And indeed, you are correct. This was a community-acquired pneumonia, and so here we see the typical right basilar infiltrate, more to perihilar, of acute onset. So let's pause for a minute and think about the significance of community-acquired pneumonia in the day-to-day practice of infectious diseases and also internal medicine. Remember that community-acquired pneumonia, #1 cause of death worldwide, I think due to infectious disease. Respiratory infections are always #1. #6 cause of death in the U.S., and in the U.S., #1 infectious cause of death. 4 million cases per year, 800,000 hospitalizations, 45,000 deaths. Enormous cost from the standpoint of hospitalizations, $20 billion cost overall annually. And we know our intuitive organisms that cause community-acquired pneumonia, and this is breaking it down by outpatients, inpatients, and ICU. And it's no surprise that Streptococcus pneumonia is #1. Haemophilus tends to be decreasing in frequency, obviously because of vaccination and other trends. Moraxella, also on this list, Chlamydophila, and we look at Staph aureus, certainly more of a significant player in the ICU. But a lot of community-acquired pneumonia remains unknown, right? We see about 10% RSV. Interesting, I participated in a recent exercise discussing the soon-to-be availability of an RSV vaccine. So it may be bundled with flu, for example, and either patients with particular immunocompromised status or those who are susceptible. We're talking about adult patients who are susceptible to RSV may be candidates for a proposed vaccine. So 90% of all pneumonia deaths are actually among the elderly. 60% rise in mortality from pneumonia over the past 15 years. 20% rise in mortality when adjusted for age. Risk factors for death are listed here and include such things as age, coronary artery disease, comorbidities, the presence of bacteremia. Although pneumococcal pneumonia deaths have decreased in recent years because we're so good at administering antibiotics, I think all of us recall a case of invasive pneumococcal disease where the patient did poorly or even died as a result. And for those of you who joined us late, we're talking about rapid diagnosis in infectious disease. So our first case study was regarding community-acquired pneumonia. So let's think about the rapid diagnostic techniques we can use to diagnose pneumonia, right? First of all, patients with acute onset of community-acquired pneumonia have very characteristic signs. We know them intuitively. Fever, cough, sputum production, shortness of breath. We may see crackles localized to exam, dullness to percussion, egophony. And what is a Faget's sign? Does anybody recall what Faget's sign is? What is that nowadays in the pulse temperature dissociation, right? So we may see pulse temperature dissociation with certain respiratory pathogens. Generally speaking, more likely to be the atypicals. Our chest X-ray is, we always talk about the 5-finger diagnosis techniques, one of which is a chest X-ray. So chest X-ray has been a long time rapid diagnostic technique for community-acquired pneumonia. And what are our rapid diagnostic tests that are available from the lab? We think about the sputum gram stain, which is still useful, but it seems like it's more difficult for us as clinicians to do due to CLIA requirements and laboratory standards and so forth. The pneumococcal and Legionella, the rapid urinary antigens. We think about quantiferon as a recently described rapid diagnostic technique because although a quantiferon test really isn't powered to diagnose a case of active tuberculosis, it certainly is one of the instruments we can use if we want to diagnose somebody with TB. And blood cultures are intuitive to us, but they're often forgot about for community-acquired pneumonia patients. And we have to kind of remind our emergency departments to obtain them because when they're positive, they can highly correlate with the etiology of the pathogen causing an acute respiratory infection, especially pneumococcus, of course. So a chest X-ray is recommended for all patients suspected of having pneumonia. In outpatients, it has maybe a little less sensitivity, higher in the emergency department. Sputum gram staining culture recommended for all inpatients. Sensitivity tends to vary. It can be as high as 90%, but sometimes, obviously, patients don't give us a good sample, and as a result, it has lower yield. Blood cultures are positive about 1 out of 10 or 11% of the time, and we can use these other diagnostic tests to help us. Now, when we do have a patient expectorate a sputum specimen, it's always a good idea to review the criteria for a good sputum specimen. We want to remind the patient to cough deeply. We want to obtain it, if possible, before antibiotics, transport it rapidly to the lab, and you see here the criteria for a good sputum specimen, greater than 25 PMNs, less than 10 epithelial cells. If specimens are outside these criteria, they will be of low yield. So these tests are sometimes appropriate for community-acquired pneumonia. Think about AFB expectorated sputums. We talked about urinary antigens. Sometimes we want to think about atypical, so we think about CF titers for Coxiella, histoplasma, and so forth. Occasionally, when we don't have a pathogen, we want to consult pulmonary for BAL. Serum cryptococcal antigen, again, a test with, you could argue with varying degrees of utility. And when patients go for bronch, think about DFA for viral antigens. More recently, of course, we have our respiratory panels, which can be very helpful, and we utilize them when they're appropriate. This is some more information about the pneumococcal urinary antigen. Again, we want to think about this test when we suspect pneumococcus. It's available a lot of times very rapidly and can be helpful in ruling in a pneumococcal infection. Now, the most recent CAP guidelines are getting older. They're from 2007. But if you look on the IDSA website, there's an update expected in the fall of 2015. So we may have newer, updated community-acquired pneumonia guidelines here in the next year or two. So of course, we associate certain risk factors for certain types of pneumonia. Remember that patients who are alcoholic are at risk for streptococcus pneumonia, but also oral anaerobes, occasionally Klebsiella, MTB, and so forth. Haemophilus and Moraxella tend to be more prevalent with COPD. Think about aspiration as an etiology for gram-negative rods and anaerobes. And as we get to some more unusual or exotic cases, if someone has exposure to birds, for example, think about chlamydophila. And HIV patients, of course, are at risk for a wide variety of pathogens, rather. And you can go through the rest of these. These, of course, are from the 2007 guidelines. The therapeutic recommendations are intuitive to all of us here. I won't go into them in a great degree of detail, but remember, you can confer with the IDSA guidelines for further elaboration. Now, how many of you are familiar with the CURB 65 scale for diagnosing pneumonia? I don't know if you've used it very much, but just to review it, you get a point for each of these: confusion, uremia, respiratory rate, blood pressure, showing evidence of hypotension, and also being over the age of 65 is also a risk factor. And depending on how many points you have, it can help you determine whether you can manage a patient in the outpatient setting, whether they require hospitalization, or whether they are at risk for not doing well if they're not in a ICU type of environment. So think about the CURB 65 rule for managing community-acquired pneumonia. So here are my pearls for the rapid diagnosis of community-acquired pneumonia. Again, utilize clinical signs, symptoms, and a chest x-ray. Remember that pneumococcus is still number one. Stratify patients by risk factors and cover appropriately. Utilize clinical prediction rules like the CURB 65, and consult with the guidelines for further information. And remember, we may have some new CAP guidelines late next year. Now, of course, it's early this year, so that means it could be 2 years from now. So look for those to be released. Yes, Rod?
Before we move on to
Yeah.
the next case, so at this point we have what we called our respiratory viral panel, right? Because it's an array of PCRs against the vast majority of the common respiratory viral pathogens. But now we have atypical organisms, with the exception of Legionella, on that panel as well. So it becomes more of a respiratory panel.
Yes.
And so it becomes more. I guess one of the questions is, at least at this institution, we're likely to order that on almost anyone who comes in with pneumonia at this point. And wonder, at what point, whether every patient really benefits from that level of diagnosis, or whether we're selective in which patients we order that on.
Yeah, I mean, I think that here at the institution I'm speaking at now, you have more of a selective patient population where it may be more appropriate because they're immunocompromised to screen for a wide variety of respiratory pathogens. In the general population, I think you might be more selective. But again, it all depends on your patient population, what their risk factors are, how immunocompromised they are. I would say in the general population that comes to a community hospital, you might be more selective. You might use other diagnostic techniques. But certainly, these rapid diagnostic sort of multi-pathogen assays are being more widely used because, again, I think they have a lot of advantages. They can reduce, if you diagnose a viral respiratory pathogen, you can reduce antibiotic utilization. If it's something treatable, you can treat them more promptly. You can avoid further testing like bronchoscopy and other more invasive diagnostic studies, and permit them to be treated more rapidly. So I think they're a big win, but from a cost standpoint, I think they're pretty expensive. In terms of a rapid diagnostic technique. In the general population, when you compare them to things like the urinary antigens in a sputum specimen and so forth. So it's a good point to bring up. All right, so here's a patient, 54-year-old guy admitted for elective cholecystectomy, did well intraoperatively but developed a minor postoperative wound infection. So he got started on Clinda. 3 days later, he got febrile and became markedly leukocytotic, and typically we look at these patients and we look for the evidence of diarrhea. Well, this patient hadn't had a bowel movement at all, so if you ask has he had diarrhea, no, he's hadn't. But then again, if you ask further, you find out that he maybe has an ileus. So Tmax of 103. He's got diffuse tenderness in the abdomen, hypoactive bowel sounds. White blood cell count of 22,000, as we said before. It looks like he's having some renal insufficiency and looking like he may be developing some acidemia as well. So again, these cases are not meant to be conundrums, but they're meant to prove a point. So what could this patient have? C. diff, right? So it's looking like this could be C. diff. And again, indeed, this was Clostridium difficile disease. So let's think about how we rapidly diagnose C. diff in patients. So first of all, patients with C. diff typically have some pretty characteristic symptoms. And that can be crampy abdominal pain, copious non-bloody diarrhea. But think about the patient, too, who develops an ileus and doesn't have a stool. And they may develop more abdominal distension, as this fortunate fellow looks to be having. And think about your exam, about the acute abdomen, the presence of rebound tenderness, and hyperactive versus quiet bowel sounds. So some patients may have hyperactive bowel sounds because they have an irritant and they have the effects of toxin in their bowel, and that can cause hyperactivity. But others may more have an ileus, so they may have quiet bowel sounds. What they don't have is normal bowel sounds, right? Think about the rapid diagnostic availability of CT scanning, looking for documentation of actual colitis or the presence of an ileus. And think about our rapid diagnostic stool studies as well. The presence of fecal leukocytes, and also, really in the last 2 to 3 years, the availability of the C. diff PCR. Now, if a colonoscopy, of course, is also a rapid diagnostic technique. So if you can get a patient to colonoscopy and we diagnose pseudomembranes, then you have your diagnosis. But most patients, I think it's accurate to say, will be diagnosed with a C. diff PCR nowadays. So I just put this up for clinical pathologic correlation of the effects of Clostridium difficile on the large bowel. And we can see the role of toxins A and B and hydrolytic enzymes, and the process by which the toxin A and B produce lysis of the lining of the colonic epithelial cells, dysfunction of the bowel, and so on and so forth. So this is a again, a colonoscopy showing the difference between the normal cecum and the abnormal bowel with the presence of pseudomembranes, and what C. diff looks like in the bowel. It's certainly, I think everyone here would say, not a pretty sight. Now, severe C. diff colitis has been increasing in prevalence. We all know that to be the fact. And in our institution, I remember attending on our institution the month before last, and I think 70% of our patients at one point had C. diff on our consult service in one form or another. So that's pretty considerable. So severe C. difficile, of course, has oftentimes been associated with this new epidemic strain, the so-called NAP strain. And this strain overproduces toxins A and B, likely related to a genetic mutation. And it also carries what's called the binary toxin. It's actually related to the iodotoxin found in C. perfringens. So we think about how pathologic C. perfringens is when it affects the bowel. It can cause necrosis and so forth. Well, here's another Clostridium strain that carries a factor that's seen in C. perfringens. Now, the NAP1 strain is fluoroquinolone resistant, and fluoroquinolone use has become the predominant risk factor for C. difficile. On our consult service, we're at my primary hospital, we had a patient who got placed on a quinolone when they got admitted, and within 48 hours they had C. diff. So we documented this just recently. So fluoroquinolones certainly are a very significant cause of Clostridium difficile. So what are my pearls for C. diff disease? Again, nowadays it seems particularly we have a high suspicion in hospitalized patients. And if you have a septic patient with risk factors and a profound leukocytosis, empiric treatment, of course, is indicated. Toxin B producing strains are becoming more common. The difference between toxin A and toxin B seemed to be more relevant when we used EIA assays, but now, because some of our EIA assays only tested for toxin A, they didn't test for toxin B, but nowadays we use the PCR, and it's kind of more of a historical point. So a more recent issue is, should we really, unless a patient is having watery stools, should we really test them for C. diff? Now that we use the PCR assays, we can't really test for soft form stools anymore. Our labs reject those specimens. So unless a patient is really having watery diarrhea, should we send a C. diff at all? Well, that's a question we need to kind of decide for ourselves. And I think where we're headed is to just test patients with watery stools, because in my primary institution, it seems like very little EIAs are being done anymore. Of course, EIAs are the only test that can be done on semi-formed stools. You can't do PCRs on those. And then lastly, what is the role of the binary toxin? It's still unclear, but it seems to be a factor in very severe C. diff disease. So what are our interventions? Since those of us in the room know them pretty well, we treat a lot of C. diff. I won't go into them in detail, other than to say that we've sort of faced this issue of whether to use fidaxomicin or not, and it seems like there's been some changes in fidaxomicin marketing, and so will we see this drug at a more cost-effective sort of point where it can be used more often? That remains to be seen. And let's not forget about the importance of a subtotal colectomy in patients with life-threatening disease. It can truly be life-saving. And stool transplants are becoming, I think, more accepted. We had one at our primary institution last year, and we're planning a second one this year. So hopefully that will become more of a role in patients who have a sort of series of relapses and don't do well with other therapy. Okay. So case number 3, 50-year-old gentleman with insulin-requiring diabetes, toe pain, had a bruise from a rock in his shoe. He felt worse, developed fever and chills, temperature of 100.5. had a 3 out of 6 systolic murmur, trace ankle edema. He had some skin findings that were significant, had a modest leukocytosis with a left shift, and had some RBCs in his urine. Okay, so who's going to take the lead on this one? What does this patient have? So I'm going to point out that he had what looked like a cellulitis. Now he presents with fever, a murmur, some skin findings, and hematuria, microscopic hematuria. So what are we thinking here? So we're thinking maybe endocarditis, right? Okay. You guys are 100% in guessing these cases. I'm very proud of you. Okay, so this was endocarditis. So let's think about rapid diagnosis in endocarditis. So it seems like nowadays we associate endocarditis with documentation of bacteremia and documentation of some endovascular lesion, right? But sometimes it's difficult to get a TE right away. So how can we diagnose endocarditis? I always like to emphasize, let's not forget the modified Duke criteria and how important they are to the diagnosis. So just to review those, because I'm always forgetting all my components of criteria, and I suspect some of you may be, most of you are probably better than me in remembering things, but it always helps to go over them nonetheless. So there are, of course, 3 components to the major criteria for the modified Duke criteria: documentation of positive blood cultures with typical pathogens, such as Staphylococcus aureus, evidence of an endovascular or endocardial lesion, and we can do that with echo, or the presence of a new murmur, right, one that has not been previously diagnosed. And then for patients with culture-negative endocarditis, they added the issue of positive serology to Coxiella. The minor criteria are listed there, and so definite infective endocarditis requires 2 major criteria, 1 major and 3 minor, or 5 minor. And you can tell someone has possible infective endocarditis if they have at least 1 major and 1 minor criteria, or 3 minor criteria. So again, just to review those. So how do we rapidly diagnose endocarditis? Well, it seems like physical diagnostic skills are falling by the wayside these days. I think we're getting too technological. But let's not forget, it's easy for most of us to detect a undocumented murmur. That's very easy. And then we want to look for sort of some of the stigmata of endocarditis. And remember that the stigmata of endocarditis date back to the days of Sir William Oehler, where a TEE was decades and maybe a century ahead, and also patients were not treated for endocarditis, so they had, there was no treatment, so a lot of times the disease process was allowed to go on for a long period of time, so they were more likely to have some of these sort of peripheral stigmata of endocarditis. Nowadays, of course, patients are diagnosed in an earlier phase, so we don't see them as often, and that's why, documenting the presence of splenomegaly, Oehler's nodes, or Janeway's lesions, or Roth spots, it's still important to document those things, but they're less common. But just to give you a refresher about these things, again, remember we look for Roth spots on the eye grounds. Janeway lesions, again, are somewhat flat, and Oehler's nodes commonly occur on the peripheral extremities. Splinter hemorrhages, most of us, if you look at your nail beds, have splinter hemorrhages. So I don't know. I have splinter hemorrhages, and I don't think I have endocarditis. But if I do, I hope one of you can take care of me. So now these are just some laboratory things to remember. Remember that endocarditis can be associated with inflammatory markers, so look for an increase in the SED rate, the presence of rheumatoid factor, and documentation of microscopic hematuria. It seems like every patient who comes in the hospital has a urinalysis, so if we're suspecting endocarditis, it's very easy to check the UA and document microscopic hematuria. Also, the difference between routine bacteremia and bacteremia associated with endocarditis is persistence, right? If you have somebody with endocarditis, they're more likely to have multiple positive blood cultures, and so we want to try to document that in patients we suspect. And depending upon your institution and how easy it is to get a TEE, remember that a TEE has greater than a 90% negative predictive value. So if you can get a TEE, you can rule out endocarditis with a certainty of 5 to 10% chance of you being wrong, which are pretty good odds. So, and a TEE can pick up vegetations less than 5 millimeters. So at some of our institutions, it's easier to get a TEE. At others, perhaps not. But if we suspect endocarditis, we really want to push for a TEE because it can be very helpful in diagnosing or ruling out endocarditis. So what are my pearls for endocarditis? So remember, subacute or SBE can present with subtle findings. The modified Duke criteria can help make the diagnosis, and TE can help rule out SBE with a, in some cases, 90% or greater negative predictive value. So those are my endocarditis pearls. So let's move on here to case number 4. And this involved a 20-year-old white female with a 1-day history of lethargy, decreased appetite, fever. They complained of headache, seemed disoriented, and the mother related there was a rash on the legs that kind of looked viral. No known ETOH or polysubstance abuse. Patient is a student at a community college. They're allergic to the mycins. I'm not sure if those are the MY-sins or the MI-sins, but some patients don't distinguish between the two. They just say mycins. All right. And this patient happened to have a splenectomy 7 years ago due to an MVA. So they're febrile, they're lethargic, they have purple rashes on both their legs, a marked leukocytosis, and bandemia. Okay, so what does this patient have? Again, these are not extremely challenging cases, but meant to prove a point. So sounds like a case of meningitis, right? Okay. Now, what kind of meningitis would you tend to see in this patient? So they're a college student, meningococcal, right? So again, it seems like in the media, whenever you hear about a case of meningitis, people just panic. But it's really the meningococcal meningitis that cause the most fear, right? Because people are very concerned about spread of meningococcal meningitis to others. So again, let's remember, let's kind of use this as a review. This is from UpToDate of the sites of entry and the type of meningitis. Remember, Neisseria meningitidis, nasopharynx, streptococcal pneumonia. Those are the two major causes of acute bacterial meningitis. But we want to think about listeria in the elderly and immunocompromised, Staph aureus in those who have bacteremia, perhaps some sort of CNS trauma, or they have implanted devices that are at risk. We also think about that with coagulase negative staph. Think about gram-negative rods in the elderly, but can also occur in all ages, and so forth. So what are our rapid diagnostic techniques in acute meningitis? We all know intuitively what symptoms patients have when they have meningitis: confusion, lethargy, fever, nausea, vomiting, and nuchal rigidity, of course, is well known, but sometimes we forget about what the Koenig and Brzezinski signs are, so I'm going to review those in just a minute. And of course, really the gold standard of diagnosis is the CSF exam. And oftentimes when we get challenging cases of possible meningitis in patients, it's because they're unable to obtain a CSF exam, and they want us to weigh in on the case. So just a refresher about the Koenig and Brzezinski sign. Remember, associate Koenig with the knee, and what you do is you lay the patient flat, flex their hip, and unfortunately, because of the meningeal irritation, you're unable to fully extend the leg at the knee, and that's the Koenig sign. And Brzezinski sign, remember, you lay them flat again, tilt their head forward, and this passive flexion of the neck, because of meningeal irritation, causes their legs to reflexively come up and bend at the knee. So for board purposes, there you have it. So this is from Netter, and it just, of course, reminds you of some of the traditional studies that are obtained in bacterial meningitis. And once again, we thought that the community-acquired pneumonia guidelines were old. Well, would you believe that it's now been 10 years since the bacterial meningitis guidelines were updated? But fortunately, if you look at the idsociety.org website, an update is expected in the fall of 2015. So again, because sometimes things lag, it could be another 2 years. So, but you know, there's not a lot of perhaps new issues in bacterial meningitis management, so perhaps that's why it's been 10 years. But I'd say every 10 years we need to update things, and there are new issues that come out. So this is, again, a management algorithm for adults with suspected bacterial meningitis, and when, of course, when you do a CT scan and when you do not. So I think we're generally pretty keyed into that. CSF findings are intuitive to us in acute bacterial meningitis. Remember the presence of, and I hope I pronounce this correctly, hypoglycemia, right? That's low glucose, elevated protein. And remember that acute bacterial meningitis, more than 70% of the time, is either Neisseria meningitidis or Streptococcus pneumonia. So these are our treatment recommendations. Again, I won't go into them in too much detail because they're intuitive to the audience in the room. But typically, of course, vancomycin plus a third-generation cephalosporin. If you suspect listeria, you can add ampicillin or penicillin G, and some people will substitute a carbapenem instead of the third-generation cephalosporin, which should cover listeria. So we all know that acute meningitis, the treatment pearl is treat first, sort it out later. You want to give antibiotics IV, of course, and give IV antibiotics first. Worry about your diagnosis later, because of course some of these cases can progress very rapidly. So again, remember of the role of dexamethasone and antimicrobial dexamethasone and therapy. We worry about this more with Streptococcus pneumonia than others, and look for the new bacterial meningitis guidelines in late 2015 or early 2016 if history is a guide. So case number 5, let me see if, okay, this is a good one. 46-year-old gentleman, 2-day history of increasing pain, fever. He thinks he got bit by a spider, and he's recently diagnosed with type 2 diabetes. He has a high fever. His cardiac, abdominal, and respiratory exam is unremarkable, but he has a red, warm, and swollen left lower extremity with a marked leukocytosis and a left shift with bandemia. Okay, so what does this patient have? Sounds like an acute lower extremity cellulitis. So most cases of acute lower extremity cellulitis, I would say, are maybe, are relatively acute, but not emergent infectious disease problems. But let's see what happened to this patient. Over the next few hours, he became agitated, worsening pain. He's restless, and he's very tender when you palpate the extremity. And you ask him, can you feel this, as you lightly stroke the skin? And he says, what? So who do you call? Surgery, right? So this patient sounds like he has a necrotizing fasciitis. So this is from about 10 years ago. One of our former fellows, Chris Cooper, and I went down to the ER and saw this gentleman with a necrotizing fasciitis. So again, he had sensory anesthesia. He had these bullae. This was in the summertime, so this was a case of Vibrio vulnificus. Yes, in Florida, summertime in Florida, exactly. So, so this was necrotizing fasciitis, and again, these patients have pain out of proportion to exam. They're very toxic. They have rapid spread of the cellulitis. This gentleman in particular had the progression of his cellulitis by several inches just while he was in the ED, as it turns out. And look for the presence of cutaneous anesthesia, woody hardness of the tissue, and a question is, does this patient, is it more important for them to receive diagnostic imaging or to go emergently to the OR? And surgery always trumps going to the CT scanner. So these patients, of course, urgent surgical debridement, submission of specimens for culture, and when you get to this point, of course, antibiotics are an adjunctive measure. Surgery is the primary treatment. So this patient had a wide debridement, and unfortunately, they also had a history of chronic liver disease, and for this particular case, the patient did not do well, and unfortunately, eventually died of the infection and his comorbidities. So these patients, even sometimes if you do rapid surgical debridement, they don't do well. And this is another type of necrotizing soft tissue infection. Of course, we all know Fournier's gangrene, and these cases can progress rather rapidly. And this is what you don't want to see, right? A dark scrotum with necrotic tissue, the presence of crepitance in a diabetic or patient with ethanol abuse history. And they also need rapid debridement. So what are my pearls for necrotizing soft tissue infections? Remember, cellulitis in the summertime in someone with aquatic exposure. Think about Vibrio vulnificus. Other pathogens, group A strep, MRSA, Clostridium. And look out for Fournier's gangrene in diabetics. Surgical debridement can be life-saving in these patients with a necrotizing skin and soft tissue infection. Now, I am going to skip this one because we just have 5 minutes, but it's basically about catheter-associated UTIs. And I want to discuss other conditions where we can use rapid diagnostic techniques. So what about bacteremia? Well, it used to be in the old days that I remember when I was a fellow in the mid-1990s, they didn't have automated blood culture diagnostic machines, so twice a day they would yank out the blood culture bottles from the incubator, stick them on the lab table, and they would hold them up to the light and look for the evidence of flocculence and growth of the blood culture bottles. So now, of course, they use automated techniques where the blood culture bottles are not read twice a day. They're read on almost a continuous basis. So really, blood culture diagnosis now is really a rapid diagnostic technique because your blood culture bottles can be called at any time of the day, not just twice a day where they used to be when I was a fellow. And so blood cultures are a rapid diagnostic technique for a variety of things. We've already talked about their relevance to acute pneumonia, but also skin and soft tissue infections and other infections as well. So when you see gram stain results reported, you can use this obviously as a rapid diagnostic technique. So when you see gram-positive cocci in clusters, that's a simple one. Think about staph species. So anytime, of course, you hear about gram-positive cocci in clusters, you can already tell the people that are consulting you, this is a staph infection, right? That's pretty easy. As opposed to gram-positive diplococci, which are what? Usually Streptococcus pneumonia. Gram-positive cocci in chains, what are those usually? So they're either strep species or enterococcus for the most part. And how about gram-positive rods? What are the gram-positive rods? So Clostridium, Listeria, Bacillus, or Corynebacterium. So remember those, the idea of gram-positive rods being called. And but also correspondingly, don't always call a gram-positive rod a diphtheroid, right, or Corynebacteria, because you may miss Listeria, you may miss Clostridium or Bacillus, or even other gram-positive rods, like gram-positive beaded rods, like Mycobacteria, which occasionally are seen. So it's often useful to call the lab and say, what is the morphology of the gram-positive rod? Is this a short rod, or is it a filamentous rod? So if that information is not reported, call the lab and ask. How about for gram negatives? What are gram variable rods? think about Acinetobacter or Bacillus. Gram-negative rods, of course, are usually not a contaminant, and gram-negative bacteremia is a diagnosis that typically requires empiric treatment. And gram-positive thin-beaded rods, I think I already mentioned this, think about acid-fast bacilli. So use gram stain techniques as your rapid diagnostic technique. Also, these are among the differential of marked leukocytosis. So you can use marked leukocytosis as a rapid diagnostic technique, potentially for things like intra-abdominal abscess, empyema, Clostridium difficile disease, or has a patient been on steroids? Do they have a leukemoid reaction? Do they have asplenia, and maybe they haven't documented it to their doctors? Or do they have a myelopoietic disorder? And remember the landmark paper by Grayson in JAMA in 1995, the idea that if you palpate bone at the base of an infected pedal ulcer, there's almost a 90% positive predictive value for the presence of underlying osteomyelitis. And of course, sometimes we extend this to the idea of pressure ulcers in someone's sacrum or ischial area. But remember, the original paper was done with the diabetic foot, so maybe sometimes you need to keep that in mind when you assert that a palpable ischium in an ulcer automatically means osteo. So just some other rapid diagnoses. Group clusters of vesicles on the genitals. What do we think about? HSV, right? How about if in a dermatome, group clusters of vesicles in a dermatome? Think about VZV. The steeple sign in a patient with, so think about acute epiglottitis, slap cheeks, parvovirus, B19. And how about target lesions in a young person with a respiratory illness? Mycoplasma, right? So think about mycoplasma. All right, so I hope this exercise has helped you all think about the rapid diagnosis of ID, and thank you all for your attention.